Well, it's my great pleasure to introduce our next speaker, Dr. Michael Yaszemski. He is Professor of Orthopedic Surgery and Biomedical Engineering at the Mayo Clinic, specializing in spinal and oncologic surgery. Significantly, he is a retired Air Force Brigadier General with over 34 years of service, retiring in 2013. He served as Deputy Commander and Surgeon at the United States Air Force Theater Hospital in Balad, Iraq in 2006, and serves currently also as Director of the Mayo Biomaterials and Tissue Engineering Lab, as well as Deputy Director of the Mayo Clinic Center for Regenerative Medicine. Thank you, Michael.
Thanks, Mike. Good morning. Always difficult to be the last obstacle between all of you and lunch, so I'll try to be on time. As Dr. Windebank said, he and I work together. You've heard a few things that I'm going to talk about, specifically the FDA importance of regulatory care in trying to get things to human use. We have a few of the same slides, so be ready for them because we talk on similar things. I'll give a little different interpretation of the patient that was missing part of his forearm, meaning that there are multiple things that picture can tell us and that patient's needs can tell us. As an outline, I'll talk about the survival rates after being wounded through all of our country's wars, military medical research needs and strategies. The needs should drive everything we do, and a few questions about the department, a few comments rather about the Department of Defense medical research funding sources. There are my disclosures. Now, survival, starting with the Revolutionary War. From Revolutionary War and Civil War, about half of people who got wounded lived and about half of them died. And you fast forward to the World Wars, a little more than half lived, but not too many more than half. Korean War, about 70%, Vietnam War, about 75%. And things that contributed to the rise in Korea and Vietnam were things that Colonel Davis talked about today: rapid evacuation of the wounded. You all remember the old MASH series, the wounded came in on helicopters, right, to surgical capability. What we've added these days is that you get care in those helicopters if it's needed, and you get care on airplanes if it's needed. And I would submit that care in the back of a C-17 is as good or better than in any intensive care unit in this country. In Iraq and Afghanistan, it's over 90%. You got a 9 in 10 chance of staying alive if you get blown up. And as was mentioned before by Colonel Davis, the trouble is people are living with more and more pieces of them missing and more functions lost, which is why all of us are interested in working in this field. Bedside to bench and back is the way at least some of us think about regenerative medicine in our civilian community. In that, we don't start at the bench. We start at the bedside with a clear description of an unmet clinical need that we then take to the lab, bring it back to the bedside, and go round and round and round again in cycles of improvement. However, it's a little bit different with respect to the military because the battlefield has different realities than even trauma in the most busy urban centers in the United States. These are slides from my friend and colleague Jim Fickey, showing that it's an austere environment. Things are blowing up, things are burning, there's smoke and vapors of different kind that you can breathe in. And these need to be taken into consideration if you think about the battlefield to the bench and back. Our service members are subject to direct and indirect fire, mines, unexploded ordnance, hazardous materials, i.e. the smoke, etc. I mean, one of the biggest things in Balad during my time there wasn't the enemy. It was we had to burn things. We had no way to get rid of materials and garbage because you really couldn't go outside unless you were an operator and able to protect yourself outside the fence, that is. And so that the garbage dump, was a source of difficult things for people. You had to live near burning garbage, which included all kinds of things that you didn't want to breathe in. And then improvised explosive devices, vehicle-borne IEDs, and explosively formed projectiles, which I gave a little picture of there on the right side. Now, clinical needs for all these. This is a fellow that I did escharotomies on. He had burns over 80% of his body. There isn't enough normal skin left on that guy to grow and cover all his burns. And yet people with 80 and higher % burns these days are staying alive. This particular guy was treated by one of our Affirm 1 colleagues, Steve Boyce at the University of Cincinnati, who developed an engineered skin. And this guy stayed alive. It took a long time, but he stayed alive. Now, I'll do the transitions with little military stories. The hospital in Balad, Iraq was the 332nd, and they were the offspring or reincarnation of the Red Tails from World War II, the Tuskegee Airmen, the African-American airmen who accompanied the bombers that you see in the lower left corner there. And they had the distinction of not losing a bomber on any mission in World War II. They were the preferred people to accompany bombers, and they went from African Americans who were told you can't be in the military and do jobs in combat to the best team to accompany bombers throughout World War II. You fast forward to Iraq, and these guys are a little old now, and the plane they're standing in front of is a little more advanced than that P-51 they flew during World War II. But they still cared about people, and they came to support the soldiers during the war in Iraq. Now, clinical needs. Here's that same picture Dr. Windebank showed. And what I wanted to say about this picture, in addition to what he said, because everything he said counts on this picture, this guy had a really good-looking hand. He had one artery going to it, and it was pink and normal looking. But what do you do in regenerative medicine? In regenerative medicine, a lot of us work and we think, well, we're islet cell people for diabetes, or we're bone people, or we're nerve people, or spinal cord people, or gastrointestinal people, etc. But this guy needs composite tissue regeneration. You can't do, he's missing skin and muscle and bone and cartilage and nerves and vessels and tendons. He's missing many tissues that have to form together. It's not we can take a bone reconstruction methodology and a cartilage reconstruction, just put them all together. We have to start thinking composite tissues. Here's another fellow, got shot up in his buttock. He's missing a piece of his femur, but more importantly, it communicates with his scrotum and preperitoneal space. This is a bad wound. And getting the tissues to regenerate in the presence of a really not happy tissue surrounding tissues is more difficult than just getting the tissues to regenerate when we do an experiment on an animal. Now, also I put this in to show the human side of war. We cared for, during my time in Iraq and in Afghanistan, we cared for 2/3 civilians, 1/3 combatants, both our soldiers, sailors, airmen, Marines, and the enemy. This girl, this 10-year-old Afghani girl, her dad just walked into a Ford Surgical Hospital with her. That's a tumor. Unfortunately, it's a benign tumor, and this just shows in different countries, not everybody gets what we get in the United States. If this little girl lived in the States, she just said, "Daddy, Mommy, my leg hurts," and this would have been taken care of when it was inside her femur. Now with the destruction of the bone, the only way to cure this is an amputation for benign disease. So there's a human side of war, and there's a different level of care that people in countries other than ours experience. Now, a little bit another transition, Civil War. This fellow, William Mayo, the founder of the Mayo practice in Rochester, Minnesota, was a Union Army surgeon in the Civil War. And what I'll mention is, of course, we're happy to be in San Antonio. When I was on active duty, I lived here for 13 years, and I miss it down here, specifically at this time of year, because it was about 0 or a couple degrees on either side of it when I left yesterday, and it was snowing. And the story we hear that those people who are still in or have been in the military will understand is when the Civil War ended, he got stationed in Minnesota in 1863. The war ended in 65. He got out of the Army in 1867, and they had 6 kids, and we hear that Mrs. Mayo said, "We've been following you around for a long time. We don't have to move anymore. We got a house and the kids are in school. We're staying right here." So a lot of us just wish his last assignment had been somewhere here in the South. Now let's go to problems. We're going to cross over from the military to the clinical, because pretty much all those advancements from the Revolutionary War on that led to a change in the survival rate from about 50% to about 90% or so get translated to clinical, to civilian practice. And arthritis is one example. That fellow I showed with his buttock blown away and missing his proximal femur and a big soft tissue wound. Now, if he gets better and if the infection gets controlled, he may need an artificial hip. This is a picture of the first artificial hip approved by the FDA, put in the United States by our former partner and chair, Mark Coventry, in 1969. Now, how did it get to be that way? There are errors in care, and as an example of errors in orthopedic surgery, that bad hip would have been treated at one time by resection. Just cut it out. The pain goes away. It's a mobile hip. You can't bear weight on it too well. You can kind of sort of walk, but you walk a little bit slow and a little bit with a limp. And later on, that era of resection turned into an era of fusion. Now you'd fuse the pelvis to the femur. The pain would go away again. It was a really worthwhile hip to work on. You could have a busy and a strenuous job and get by, but you gave up motion. You had no motion in that, and you walked with a limp, which likely accelerated the other joints' deterioration in your leg. Then we went to an era of replacement, which you just saw, that first total hip, and we're now entering an era of regeneration. And in regeneration, in addition to everything else that's necessary, it's all about the cells. The cells have to make the matrix to make the appropriate tissues. And it's also all about keeping thinking about it. This is Sir John Charnley, who put the first total hip in about 1958. And of the things he had there is a stainless steel ball and stem that went into the thigh bone. He started out with Teflon. That rapidly went away. So those of us who deal with materials to go with the cells, we got to think a lot about the materials. Almost every one he put in, the Teflon wore out. He changed in 1960 to polyethylene. And with minor changes, that polyethylene is still the preferred part for the socket of a total hip. The metal has given way to cobalt chrome molybdenum for the ball, to titanium niobium molybdenum alloy, titanium aluminum niobium alloy for the stem, but pretty much like he thought it. The PMMA, the polymethyl methacrylate, 20 years ago, 90% of hips were fixed in the femur with PMMA. Then we learned about osseointegration and calcium hydroxyapatite coating so that the bone could grow into the hip, and about 90% of them today are done without cement. That has changed the longevity of these hips from about 8 to 10 years when they were done with PMMA cement to probably about 20 or more years now since they've been putting them in with osseointegration. So once we get something, is what I'm driving at here, we need to keep improving and improving and improving. Now, tissue engineering, as I mentioned, is all about the cells. Bone cells got to make bone tissue, cartilage cells make cartilage tissue, and so on. I'll give a few examples here about the cells and how we have to think of ways to use them that will fit in with the care of the patient. Right now, if we have a contained defect, that is a hole in the bone, there are, at last time I checked, 52 or so bone void fillers approved by the FDA on the market, which means none of them is really much better than any others, and you take your pick which one you use. But the bone grafting, typically today, is done at the time of the surgery. Now, for those wounds we saw as military wounds, that's not a real healthy environment to have cells try to anchor, live, proliferate, secrete their matrix, make the tissue. And it might be a better idea to think a little differently and think, can we get the wound better first, and then perhaps have cells that we do something to outside the body and put them in later when the healing environment for bone regeneration is better. I believe we're going to have to think differently from the way we surgeons behave now and put things back together. I put this in, this is a craniofacial reconstruction of a mandible to remind us that there are many different kind of physicians that take care of bone regeneration. As an orthopedist, this is not something I do, but the principles of the biology are the same for the plastic surgeon, craniofacial surgeon who puts these wounds of the mandible and oral cavity together as they are for the extremity wounds. And this is one where there's contamination nearby always, because the mouth is a haven for bacteria, and a lot of these wounds that our soldiers, sailors, airmen, Marines get have communication between the outside wound and the oral cavity. Now, just as a show of some of the scaffold, these are scaffolds that we make. This is the work of my partner, Li Chun Lu. And we can deliver cells and biomolecules from these, from the porosity in the scaffold where we want the tissue to form, through micropores that are made by microparticles that contain either the growth factor or the antibiotic or whatever molecule we desire to deliver to the cells. And the cells can be many different kinds. We've chosen to use either autologous bone marrow stromal cells that we expand and differentiate ex vivo and then put in once the scaffold is vascularized through the help of our cell biologist, Andre Van Wijnen, in our group at Mayo. Now, other tissues. Here's a fellow got shot with a high velocity projectile. On the right side of the picture, you see we're putting the sucker in through the entrance hole, and I'm holding up the exit wound. This guy is missing a lot of muscle. He's going to scar in, and from an infection perspective, he'll do fine. He's missing a lot of his quadriceps and a lot of his adductors. He's going to have trouble with pulling his knees together on that side and extending his knee on that side. So other tissue regeneration, composite regeneration, muscle regeneration is a big deal. We don't really have a good answer for it, although through Affirm 1, some answers are coming to light. The clinical needs are for the volumetric muscle loss. If there's nerve loss, the muscle will get atrophic before and if a nerve regeneration is successful. The clinical issues are the innervation, as I just mentioned, and the musculotendinous junction. How if the muscle's gone where it hooks into the tendon, that's one of a number of specialized connections between tissues of different type that's going to have to be thought of if we're going to do functional regeneration. Once again, it needs to be composite tissue regeneration. Now, how about that tendon at the end of the muscle that's missing, or other type of collagenous tissue, a ligament that goes from bone to bone across a joint? They can happen in trauma, and along the paradigm of things that we figure out for our soldiers, sailors, airmen, Marines will translate to our civilian population. Degenerative tendon tears happen as we age. The issues are, again, the musculotendinous junction and the enthesis, where the tendon or ligament goes into bone. This is a specialized junction. Any of you who have had a rotator cuff repaired know it's not as good as before you had it fixed, because where that tendon's hooked back into your proximal humerus doesn't heal with the same amount of strength as it had before it tore. Some of them are in an intrasynovial environment. Any of you have had an ACL reconstruction. Your ACL, your anterior cruciate ligament, is intra-articular but extrasynovial. Once it tears, that distinction is gone, that separation, and the regenerating piece that gets put in, whatever it may be, is in the synovial fluid, which seems to be a barrier to regeneration. Again, we got to figure out how to do composite tissues. This is the work of one of the polymer chemists in our group, Brett Runge. In thinking about tendinous tissues, we wanted to make a scaffold that would bear tensile loads rather than compressive loads. He made this copolymer between PMMA and PCLF that's self-assembled into these parallel tensile fibers upon which we put cells. This is a blow-up of one of the bone scaffolds. The black areas are the pores in the scaffolds. The red is a stain on collagen. So we put the tensile load-bearing scaffold on the struts of the pores of the bone scaffold, and that bone scaffold has collagen growing all through it. Now, if bone happens, of course, we're hoping that maybe that'll be a better connection between the collagenous tissues that are forming there and the bone tissue that'll form within the scaffold. But this is a rudimentary attempt at trying to regenerate two tissues at once and have them do so in a functional manner. Now we'll transition again. This was given to me by my colleague, General Gorent in Iraq. Pretty nice demonstration of discipline. Now, funding sources. The Affirm, we've heard about a lot. I've mentioned that to myself and to friends and colleagues that Affirm 1 made traditional competitors into friendly collaborators. As Dr. Windebank mentioned, we shared with each other all the secrets in our labs. We had other labs do the testing on what we came up with, and it really turned out to be a good accelerator of translation to humans. The CDMRP, the Congressionally Directed Medical Research Programs, includes, I'll do a separate slide, I'll not go into that. The DARPA, Defense Advanced Research Projects Agency, and the service-specific research funding opportunities. Now, Affirm, there's sometimes contracts, unlike the NIH, which offers grants, and Dr. Windebank went over the reporting requirements with milestones that are very important in any DoD grant that's a contract rather than a grant. There's timelines and deliverables required. The reporting requirements are very much more comprehensive than the NIH. And we have to look at technology readiness levels from 1 to 9 and show the government objectively that we are progressing to higher levels of readiness for the intended use of the implant. The CDMRP program began in 1992. Since its inception, it's made about 12,000 awards, totaling about $8 million. There are 20 current research areas within its portfolio. Funding mechanism includes, this is a DoD funding source that includes grants and contracts and cooperative agreements. The one I know something about is the peer-reviewed orthopedic research program. Dr. Fickey and I have co-chaired the integration panel for the PRORP for the first 5 years of its existence. And the new chair this year will be Colonel Romney Anderson. I will say that I put the PRORP up to say the most important thing from one person's opinion about applying to the DoD is read the directions. More grants that were put into the PRORP never made it to the integration panel for scientific review because the grant proposer did not make it clear what aspect of the request for proposals, what area of science their grant applied to. And if it wasn't immediately obvious to one of the administrative people by just reading the first page, it got sent back without review. So please be certain, even more critical I think than the NIH, is read the directions for DoD grants and be certain that you make it clear that you are answering one of the requested areas of need. One of the things that came out of the CDMRP is METRIC, the Massive Extremity Trauma Research Consortium. This group I think there's a total of 20-some sites now around the country. This was funded at a level of over $50 million. And just like the Affirm, it made collaborators out of research competitors. They share data, they share their analysis of the data at their institution they put into the center. This includes a center for evaluation at the Johns Hopkins School of Public Health with Ellen McKenzie as the person in charge. So all the surgeons agree on ways that they're going to treat things. They send their results to Dr. McKenzie. Many studies in orthopedics, like LEAP, the Lower Extremity Amputation Project, many of these studies were done at multiple sites that just wouldn't have been done without the funding of the CDMRP, peer-reviewed orthopedic research program that made METRIC. Another thing that I'll mention about these programs is when you're thinking about a grant, they'll often put the level of support that they believe is going to happen. I'll say how it happened for us at the PRORP. The standard level of support is $30 million a year by Congress. That was the line item. And in different years, there have been what seems to be a bad word in Congress, earmarks. But in this case, I don't think too many people would argue that earmarks to help the wounded warriors are okay. Congressman Murtha from Pennsylvania, the year that we awarded the METRIC, rest in peace, he's now deceased and was a World War II veteran and a very active supporter of care of our military folks, got an earmark that made our kitty that year go from 30 million to 100 million. So I mentioned, I think we spent about 60 of that 100 million on METRIC. So really through the work and energy of Congressman Murtha, METRIC was born, which is already having great impact on how we treat our wounded with extremity trauma, and it has had translation to civilian trauma already in the first 5 years of its existence. Now DARPA, the Defense Advanced Research Projects Agency, began in 1958 as the Advanced Research Projects Agency during President Eisenhower's administration to keep the U.S. technologically ahead of its potential enemies. It was a response to the launching of Sputnik, which was a surprise to us. The strategy is high risk, high reward. Like the others, you have to respond to something that they're asking for. I will say that with respect to high risk, high reward, I was asked a couple years back to discuss the development of a buddy treatment for an open tibial fracture. That would be something that the buddy could put on that would make the leg stable and the wounded person would just get up and walk away. And I said to the person who's coming, I said, no surgeon's going to be okay with that, because these wounds, they're dirty. They got grass and dirt in them and clothing in them and metal particles. They need to be splinted and washed out as a first thing. And he said, so you're telling me it's impossible? I said, I think from a clinical perspective it's impossible. He said, great, that's just what we want. We make the impossible possible, so God bless them if they can do that. One surgeon here will be happy about it, but I don't think so. Now, what have they accomplished? They were developed as the ARPANET in the 60s. The ARPANET was developed in the 60s as a hardened communication system. It was the precursor to today's internet. DOD and NIH have funded the things that I've talked about from research, as has a firm. This is what we like to say Mayo Clinic looks like. Actually, when I left, it looked like this. And I'm real happy to be in San Antonio, and thank you for your attention.